Hi everyone, I'm Maya Buch. I'm from the University of Manchester, rheumatologist, and it's a real pleasure to be introducing you to this CSF webinar today on the clinical application of recommendations on the use of JAK inhibitors of inflammatory arthritis. It's a topical area, clinically very pertinent, and I'm looking forward to really quite a rich discussion that will follow the agenda with the various talks. Let me first introduce the faculty, benefit from really very esteemed speakers and expertise, as you can see here. Professor Anja Strangfeld from University Medicine Berlin and co-founder of the Rabbit Registry, Professor Chris Edwards from University of Southampton in the UK, and Professor Dagna from Milan in Italy. And we've got three great talks that will essentially work towards building the discussion, hopefully, around JAK inhibitor use in inflammatory arthritis. Just for some housekeeping, you'll note that you're all on mute for the duration of the meeting. Please do enter questions, and this can be at any stage of the webinar. There will be, as you'll hear shortly, dedicated time for question and answers, but please do submit any questions through the Q&A function that you'll see on the toolbar at the bottom. If you do have any questions, any problems, any technical issues, please use the chat box. So this is the agenda. As I was alluding to earlier, we'll be essentially hearing a series of talks initially from Professor Strangfeld on our understandings of JAK inhibitor safety. And this will particularly touch upon recent data that I think we're all aware of, particularly in relation to cardiovascular events and malignancy. And Anja will be putting all these clinical trial and real-world evidence data together to give us a better understanding of the overall safety profile. We'll then hear from Professor Edwards, Chris Edwards, on the recent update of the EULAR 2022 recommendations. And this will essentially be drawing on the evidence base that Anja will be speaking to, as well as the efficacy data. And Chris will give us a good insight and perspective as to how these updates came about and the fundamental essence of the updates and any changes from previous. And then we'll hear from Professor Dagna, and this will really bring all the elements together, because fundamentally it's about integrating this understanding of safety and recommendations through a rigorous process in terms of our day-to-day clinical decision-making for our individual patients. And Lorenzo will be really highlighting the considerations from that clinical perspective, so we can all go away with a pragmatic understanding of how to apply JAK inhibitors and apply the data and understanding on that clinical level. As I mentioned before, there'll be plenty of opportunity for Q&A, so hopefully we'll have a rich discussion. Please don't hesitate to put any of your questions in that question box, and then there'll be a bit of time for just summary and close, just to wrap things up. So without any further delay, it gives me great pleasure to introduce Anja Strangfeld, who will be talking on the latest understandings of JAK inhibitor safety. Anja, thanks so much.
Thank you, Maya. Dear colleagues, it's my great pleasure to be here with you today and to present some of the data that were published lately with regard to the safety of JAK inhibitors beyond the very much discussed results from the oral surveillance study. These are my, I have to say, these are my disclosures. Yeah, mainly due to my function as PI of the Rabbit Register. And this is the outline of my talk, and I don't want to start without a very short introduction into the oral surveillance study, which was mandated by the FDA after increased serum lipid levels and cancer occurred in the RCTs of JAK inhibitors, and they required a head-to-head study analyzing JAK inhibitor safety versus treatments with TNF inhibitors. And this slide is from the ACR. I borrowed it, and the patients that were included in the oral surveillance study were cardiovascular enriched patient population. They had to be above 50 years of age, and they had to have at least one additional CV risk factors. They had to have moderate to severe RA, and then they were randomized to receive either tofacitinib 5 or 10 milligram per day or TNF inhibitor. And one specialty of this study is that they received adalimumab when they were residing in North America, and etanercept when they were from any other country of the world. So in 2019, there was a protocol amendment, and all patients with the higher dose, 10 milligram twice a day, were switched to receive only 5 milligram twice a day. A specialty of this study was that it was an endpoint-driven study, so it was considered to be complete when more than 1,500 patients were followed for more than 3 years, or when more than 103 major cardiovascular events or more than 138 malignancies have been reported. And another specialty of the design is that it was a non-inferior design, which means that tofacitinib was considered to be non-inferior to TNF inhibitors if the upper level of the confidence interval for safety events was lower than 1.8. So we will see here what this means. These are incidence rates of major cardiovascular events in the tofacitinib treated patient groups with 5 and 10 milligrams shown here, and these are the incidence rates for TNF inhibitor treated patients. And you see there's a numerically increased incidence in patients treated with tofacitinib, but adjusted for other factors, there was no significant increased risk shown for the tofacitinib treated patients compared to the TNF inhibitor treated patients. But now we have the non-inferior design, which says if the upper level of the confidence interval, which is this one, is exceeding this defined margin, then tofacitinib is not considered to be non-inferior. So this was the a very big topic where we were talking about and discussing about. It is different with the cancer occurrence here. The crude incidence rates were not significantly different. You can see it here for the combined tofacitinib dose and for the TNF inhibitor doses. But the hazard ratio indicated a significant 1.5-fold higher risk with tofacitinib treatment compared to TNF inhibitor treatment. And this was true for the 5 milligram twice a day and for the 10 milligram twice a day patient population. So a difference was that the most frequent cancer in tofacitinib treated patients had lung cancer, and in TNF inhibitor treated patients, this was breast cancer. In summary, in the oral surveillance study, we had a hazard ratio for major cardiovascular events, which was higher, but not significantly increased. But due to the non-inferior design, the criteria for non-inferiority was not met. And differently for the cancers, JAK inhibitors were significantly associated with higher risk for cancer. There was a post hoc analysis of the oral surveillance studies, which showed that the risk of major cardiovascular events did not appear to be different with tofacitinib 5 milligram twice a day versus TNF inhibitors in patients that did not have any cardiovascular risk factors or any history of cardiovascular disease. So let's go now to the non-interventional, non-randomized real-world data. And I will start with the herpes zoster, which was also found already in the RCTs, that there's an increased risk for JAK inhibitor-treated patients to develop herpes zoster. But there are not so many studies that showing it across all treatments. And these are data from our rabbit register, and you can see very clearly that based on 559 herpes zoster events, that there is a remarkable increase in patients that are treated with JAK inhibitors, not only regarding the non-serious events, but also the serious herpes zoster events. That means patients receiving that treatment are also at increased risk to develop ophthalmic herpes zoster or long-term sequelae of the herpes zoster. And not only patients treated with JAK inhibitors are at increased risk, but also with some other BD-MARDs. Other risk factors are age and glucocorticoid treatment, and so the recommendation would be to vaccine patients before they receive any of those treatments or before they have these risk factors. Regarding serious infections, there were some claims data analysis in the early years. The time period here for the selection of patients was 2011 to 2014. And this was a time where the JAK inhibitors were not even approved for the treatment of RA in Europe. And you can see here higher rates for tofacitinib-treated patients with serious infections compared to all the other treatment categories, but there was, if you take into account different patient characteristics, there was no clear association of higher risk for serious infections with the treatment of tofacitinib. But there were other risk factors that were seen: prior BD-MARD treatment, prior serious infections, glucocorticoids, especially at higher doses, and higher age. Another study who took data from several phases of clinical trials, tofacitinib studies with control arms, and who completed the data with cohort study data from the COREVITAS register, showed that there's a higher incidence of serious infections in older patients versus younger patients. I think this is not a very surprising result, but what was surprising was that this was not so different tofacitinib-treated patients regarding in comparison to TNF inhibitor-treated patients. In younger age groups, there was no real difference, but in elderly patients, it seemed that the age modified in this dosage group the risk, and that it was even deemed higher. So the authors concluded that their data support the globally recommended dose of 5 milligrams twice a day for RA patients. And I have to say, if I look at our RABBIT register, and I think you have the same experience in your clinical practice, that patients are mainly treated with a 5 milligram dose. In the RABBIT register, it's about 97% of the patients are treated with a 5 milligram dose twice a day. 2% even have a lower dosage, and only 1% is different. We have looked at serious infections, especially in elderly patients, and selected more than 2,200 patients in the age of over 70 years from our cohort. And as you can see here, the incidence rates or event rates of serious infections were quite similar, distributed in all kinds of treatments. What we also found that the incidence rates in total are quite high in comparison to younger patients. It's twice as high as in the total cohorts and 3 times as high as in young patients in this elderly cohort, but they have a lot of comorbidities, and it's not very surprising, this result. But you can see that there's no difference regarding the treatments they received. We found other risk factors that were associated with serious infections, as the other authors as well: comorbidities, glucocorticoid use, higher disease activity, and a very important lower physical function. Regarding major cardiovascular events, which data is out now from the real world? There are analyses from the forward cohort. This is a US register with long-term follow-up, and nearly 20,000 patients were included in this analysis, and the authors analyzed a combined endpoint regarding major cardiovascular events. And they identified more than 1,800 events. And because these were so many events, they were able to adjust for a lot of factors which are important, especially in the US, like insurance, work situation, education level. And with adjusting for all these factors, they found that treatment with TNF inhibitors or with abatacept was associated with a lower risk for the occurrence of major cardiovascular events. And you can see here for the other treatments, BTMA treatments, and for tofacitinib, that they did not find any increased risk for those treatments. It is shown here in detail, again, for the different TNF inhibitors, for example, no increased risk, but decreased risk even, but glucocorticoids again seem to be increasing the risk for major cardiovascular events. Tofacitinib treated patients only had one event in 301 exposures. This is another analysis from the US using claims data. They used 3 databases, and it is known as the STAR-RA study. And they were looking at major cardiovascular events. They defined the major cardiovascular events as being either myocardial infarction or stroke. They performed their analysis in an unselected patient cohort with an incidence rates of 1.3 in tofacitinib-treated patients, 1.24 in TNF inhibitor-treated patients, and the pooled weighted hazard ratio adjusted for patient characteristics was 1, so no difference at all. In a selected cohort, again, cardiovascular enriched cohort, similar to the oral surveillance study, they had higher incidence rates with 1.83 in tofacitinib-treated patients compared to TNF inhibitor-treated patients with 1.46. But the pooled weighted hazard ratio did not show a significant increase. Maybe a tendency, but not a significant increase. The results are shown here again graphically. And what I found was really interesting was that they also performed a sub-analysis with patients stratified regarding their cardiovascular disease history. And they found that in patients with cardiovascular disease in the history, the pooled weighted hazard ratio was not significantly still, but maybe a little bit increased. And in patients without this cardiovascular disease history or actual cardiovascular disease, you can see that there's no increased risk for patients treated with tofacitinib in comparison to patients treated with TNF inhibitors. Other claims data that I found for Europe, for example, are coming from France. They analyzed more than 15,000, nearly 16,000 patients initiating either JAK inhibitors or adalimumab, and they found higher incidence rates of major cardiovascular events, which were not significantly different from each other. But for venous thromboembolic events, they found also higher incidence in JAK inhibitor-treated patients. And this increase was significant. What I want to point out to is that in patients exposed to adalimumab, the frequency of deep venous thrombosis was higher than the frequency of pulmonary embolisms. And this relation was was reversed in the JAK inhibitor treated patients, where here the number of pulmonary embolisms was higher than the number of deep venous thrombosis. Adjusted for the different patient characteristics in those patients, there was no increased risk shown either for MACE or for VTEs in patients treated with tofacitinib in comparison to adalimumab. We also did a similar study in our RABBIT register. We selected patients who started since 2017. This was the year of approval of JAK inhibitors in Europe, either JAK inhibitors, TNF inhibitors, or CSD-MATs. We also selected a cardiovascular enriched patient population, and we did not find so many MACE events at that data cut, and you can see there's no increase across the treatments seen for the JAK inhibitor treated patients. You can see that in those patients that are cardiovascular enriched, nearly all events happened in those patient population, 27 of those 28 events. And when we compare our rates with the oral surveillance rates and the STAR-RA rates, we can see that in the US, the incidence rates are much higher than shown in Germany, for example. And we have similar rates than shown in the oral surveillance. In our multivariable adjusted analysis, we found comorbidities and glucocorticoids, especially as risk factors for major cardiovascular events, but not JAK inhibitor treatment. And last but not least, venous thrombotic events. First, let's look at the background risk for venous thrombotic events in RA patients. We can see here that this is that the RA patients, that the risk for venous thrombotic events in RA patients is twice as high as in the general population. And no increased risk was found for tofacitinib in a study from the US register COEVITAS, and with actualized data here with more events, there was also no increased risk found, which was different in the Swedish analysis, which was published just now. And you can see here in patients that were treated with B or T STIMATs, there is a higher incidence rates for VTEs compared to those not receiving B or T STIMATs, and again, twice as high as in the general population. And if we they stratified it regarding the treatment, and you can see a significant increase under patients treated with JAK inhibitors. And they, in addition, found a 50 times higher rate in males than in females, and a 9 times higher occurrence of VTEs in patients with prior VTE events. This Kaplan-Meier curve shows you the occurrence of VTE events in JAK inhibitor treated patients, shown here with this curve. And these are the other treated patients, and this is the general population curve. And what was very interesting was that they also found a higher rate for pulmonary embolisms, and which verified the disproportionate ratio shown in the RCTs and also in the oral surveillance already. So they concluded that their results add to the concern regarding cardiovascular safety of JAK inhibitors, but they say this must be weighed against the risk of inadequate treatment of disease activity. And this we have to bear in mind if we judge the results from all the RCTs and real-world data. And one remark from me, I was wondering, why is there no increase of MACE in real-world data, but in the RCTs? And I thought it could be maybe because we don't randomize in clinical practice. Treatment which is considered to be adequate will be prescribed to the individual patient. So we are not prescribing the same treatment for different patients. We are not randomizing treatments to those patients. No, we look at the patients and we prescribe the treatment adjusted for their patient characteristics. And this might also equalize the risk that we put the patients on. So in summary, we have a numerically increased risk for major cardiovascular events and a significantly increased risk for cancer occurrence in the oral-surveillance study. We find no increase with the tofacitinib 5 mg twice a day versus TNF inhibitors in patients without severe risk factors or history. And the real-world data did not find a significant increased risk for serious infections with JAK inhibitor treatment, nor did they show an increased risk for MACE or VTEs, except for the Swedish data that found a significantly higher risk for VTE in patients treated with JAK inhibitors, mainly resulting from an increased risk for pulmonary embolisms. And I think this points us to the future. We should have a better knowledge of the pathophysiology of the JAK-STAT pathway and also look at differentiations between the JAK inhibitors. We have to look more at the lung tissues, maybe inflammation does something different in these tissues. We have to have more data that is able to take the benefit of reducing the disease activity with that treatments into account. And we should have more data for the subgroups of patients to direct treatment decision and guide advice to our patients. And I thank you very much for your attention, and I'm looking forward to the discussion and to the talks from my colleagues. Thank you.
So we'll now move on to Professor Chris Edwards. That was a great, I think, summary and actually detail of the RCT and real-world evidence of safety of JAK inhibitors. Chris, handing over to you to give us your insights into the EULAR 2022 recommendations update.
Yeah, thank you very much, Maya, and wonderful to follow Anja's great talk, which really summarized things really well. And I think probably my task is to look at the new recommendations as were presented at EULAR in Copenhagen, show you where there are differences from what's still published in ARD and on the EULAR website. But of course, we're focusing on around the ordering of JAK inhibitors and biological therapies and thinking about that relative risk and benefit of the therapies we're using. And there are a few key themes, because I think EULAR recommendations review is also a way of thinking about what the FDA says, what the European Medicines Agency says, and there's a bit of an update around one of the safety committees related to EMA as well. So we can work our way through it. But some other themes are around, do we include JAK inhibitors as a group? Is tofacitinib different? Do we identify a high-risk group of patients and are really careful for those, or are we careful for everybody, and how we look at the risks for MACE and malignancy in our populations? Okay, so here's my disclosures, and the other one to add is I was part of the steering committee that produced this version of the EULAR guidelines, which, as I said, are in the process. They're in press at the moment. Okay, so things to look out for. One of the things during the production of the newer version of the recommendations that was considered was where there are differences with other organisations, because those sorts of tensions are always great opportunities for us to think why there are differences. And there were some around corticosteroids. We're of course going to talk around the ordering of advanced therapies, where you put biologics and JAK inhibitors, and a bit about tapering. And actually, when I think about it, probably all of these have a relevance to safety as well, don't they? So we'll come to differences with corticosteroids, which might promote cardiovascular risk as well. Clearly, we're going to talk about the JAK inhibitors, but also tapering may be an issue. If oral surveillance tells us that relatively there's less cardiovascular events in individuals receiving TNF inhibitors, does that change the way we think about the tapering of the therapies we use? Are there benefits we might be missing out on? So I was going to try and think more broadly. Okay, so there's no confusion. This is the current version of the EULAR guideline. So this is referenced 2020 in ARD. This is what's on the EULAR website, but I'm going to contrast that with what has now been suggested and presented in preliminary format at the EULAR Congress in Copenhagen. And you'll know the background to this. So we start off with rheumatoid at the top. If there's no contraindication, we use methotrexate. We talk about the use of short-term glucocorticoids, and you'll see the newer version has tightened that up a bit, because the ACR view is we should be a bit more strict about trying to avoid using glucocorticoids. And that's very relevant in a discussion around MACE events and other comorbidities. And then we need a little bit of time. We aim for our targets of low disease activity and remission, and we want improvement within 3 months, and we want to achieve the target within 6 months. But if we fail, the previous guidance says we look to see if there are prognostic factors that are poor. And if there's lots of rheumatoid factor and anti-CCP, we might consider a biologic or a JAK inhibitor. So this was the previous status quo. This was treat biological therapies and JAK inhibitors at the same level of evidence. But then, of course, the evidence that Anja has so beautifully presented comes along, and oral surveillance comes along, and it makes us reconsider that along with other regulatory authorities as well. Okay, so then if the first biologics or JAK inhibitors don't work, then you get to move on to a different biologic or JAK inhibitor. Of course, the risk is slightly different here because you're now moving into a group of people who have resistant disease by definition. And so the risk benefit clearly changes. And then over on the right-hand side, there's discussion around the possibility of tapering, which I've touched on already. Okay, so now let's move on to thinking about how things have changed and how things have stayed exactly the same. Now, you'll know the process. So there are a number of systematic literature reviews that were done. So for this update, there was one done on efficacy, which is always done. There's one on safety, and then there was one done on glucocorticoids, which was done because of that difference with ACR. And then there's a process of discussion and looking at the data, and you come up with various different suggestions for recommendations. And then people have a fight over it intellectually, and you try and come to a compromise position. So there are overarching principles, and I was looking particularly for where these are influenced by safety or influence safety. So first of all, these are unchanged. Treatment of patient aim at best care clearly, and it's a shared decision. That comes back to risk and benefit, doesn't it? And discussing what the risk and benefit are for therapies, and that you should take into account all of those. That's in B. And then if we look down to D, the need to have multiple different mechanisms of action of therapies is important. And it is important in the discussion about where the risk and benefit sits for JAK inhibitors and how strict we are in terms of our concern over the risks that have just been described. Okay, so here are recommendations 1 to 5. These are unchanged, and these enshrine some of the basic principles of how we treat rheumatoid, that we should see individuals as soon as possible. We should start treatment with DMARD soon. We should aim for a target, and we should be restless. We should keep changing things until we achieve the targets that we're aiming for. Methotrexate is usually part of that strategy. Personally, I'm quite a fan where people will take it of methotrexate because it does other things as well, doesn't it? It reduces cardiovascular risk. It's a bit of evidence it might improve cognitive functioning and be associated with less dementia in patients with rheumatoid arthritis, sort of tantalizing bits of information which might support us using it. And then we might use other CSD-MARDs if methotrexate is not appropriate. So a couple of things to say about difference. I won't labour the point with this, but ACR now is much more strict about corticosteroids in their guidelines and really try not to use it, and if you do, for a short time. If I mention the discussions around corticosteroids in the update of the EULAR recommendations, it was around efficacy is proven. Steroids work and are effective in treating disease, and they're disease modifying. Steroids, though, cause dangerous side effects. But if you look at most of the evidence and the literature review, you need 5 milligrams plus for more than 6 months for that to be really shown. So there may be a case for using steroids in the shorter term, but then take them away. And that's the sort of summary I would leave you with. Now, as a result of that, And as a result of that discussion, the recommendation on the left-hand side has changed a little bit. And it was around tapering corticosteroids as rapidly as feasibly possible. And now it says tapered and discontinued. And that is to signal the fact that steroids are great in the short term, but let's try and stop them. And, you know, that's relevant to any discussion about comorbidities and cardiovascular risk. Okay, so the main course of this presentation is around thinking about the ordering of biological therapies and JAK inhibitors and the the logic around this. And it's a time to look at what the FDA says, what the European Medicines Agency says, and how we might feel about the way we should be using JAK inhibitors in the populations. And it's all about looking at the data from a robust study, a randomized control study, oral surveillance, and seeing does that have implications and what are the implications, and is it JAK inhibitors all or is it tofacitinib only? So here's the positions up until recently. So FDA, I don't think this has changed. EMA is probably about to change as a result of the PRAC process. So that's an advisory committee that looks at safety on behalf of EMA. So if you look at the FDA at the top, essentially it's saying use a TNF inhibitor first and then have a really good think about risks, and you may think about JAK inhibitors at that point, but go for TNF inhibitors first. To be honest, that's often what happens because of the price of biosimilar anti-TNFs. That's certainly commonly done in the environment I work within in the UK. But that's the FDA, so TNF inhibitors first. And then the EMA's view has been really think hard about those at risk people that have been identified from the trials and make it specific for tofacitinib and don't consider all of the JAK inhibitors in the same way. Okay, so when you're weighing up the use, we need to think about efficacy and we need to think about adverse events as well. And I'm not going to spend much time on this, but there are 4 big studies with the JAK inhibitors that are available to us that all show either superiority or non-inferiority of these therapies, so that they work. There's efficacy across a whole load of endpoints, including disease modification and radiographic change. Now, Anja has presented this beautifully, and I'm not going to spend much time on it. I think the things that I pull out of it are the relative risk against TNF inhibitors. That's clear in my mind, I think, now. The identification of who the higher risk patients are. So if we wanted to have clinical recommendations that says who we might be cautious with using JAK inhibitor, it is those smokers, older patients, aspirin users, perhaps male, the other risk factors that are present. And the other thing that I'm always drawn to is the numbers needed to harm on sort of the top right-hand side for malignancy, and trying to get just how big is this? How big is this problem? How much do I need to consider it? And if you look at the 50 plus individuals that need to be treated with a JAK inhibitor with tofacitinib here, over the anti-TNF over a 5-year period to see these events, I think that probably puts it into context as well. We've already heard that the randomized control study shows this difference, but not all of the observational studies or registries do. This is one from the US, just as an example. But it just raises that point and discussion around why is there that difference? Do we already avoid those patients at higher risk in the real world? Are we already sort of pre-screening them out of being treated? And that creates perhaps a bias in what we're seeing. Okay, so what's happened as a result? So this is what the EULAR recommendations that were presented in the preliminary form by Joseph Smolin in Copenhagen say. And that's about thinking about biological therapies, and then you may consider a JAK inhibitor having taken into account these risk factors. So this is risk factor based. This is saying that in general, biologic here at the top, but consider JAK inhibitors. And that's in contrast a bit to what the FDA says. And we'll look a bit more at what those risk factors are defined as being. So it's a shift in the relative balance of where we think we should be used. Okay, so then here's an update of some information. So this was published on the 28th of October, so just a few days ago. And this is from the European Medicines Agency. And the process is they start a process called Article 20. and that leads to a risk assessment by the Pharmacovigilance Risk Assessment Committee. And they go through the available data, they look at the trial data that's available, they look at other forms of data, and then they seek expert advice as well. And you won't be surprised to hear that rheumatologists, dermatologists, and gastroenterologists were spoken to. And then they weigh up the risk and they make a recommendation. And then that goes back to EMA and that goes through the European Commission. So this is still in process, but the safety recommendation is this. So they've had a look and they believe that there is an increased risk of MACE, VTE malignancy associated with tofacitinib relative to TNF inhibitors. And that relative word, I think, is important. And it was also concluded that the risk is across all of the JAK inhibitors, that we shouldn't separate out tofacitinib, that it would be safer to consider them all as one group. So that's where that is. And here's the sort of summary of that. So PRAC has recommended measures to minimize the risk of adverse events associated with JAK inhibitor use. And the committee recommended restricted use in those groups only if and to be used only if no suitable treatment alternatives are available. So it is dividing people up into high and low risk, and it's thinking about whether you have an alternative to use prior to using in those higher risk groups. And then there's also a comment, and Anja made that point, didn't she, around DVTs and pulmonary emboli, and whether there's a difference between the pathophysiology and the risk for clots originating in the lungs versus originating in the deep veins of the legs. So that's the PRAC bit. Okay, so keep moving on through. So here's recommendation number 9, only a tiny thing here. So this is about if you can't use a CSD-MARD, for example, if someone's intolerant of methotrexate, you may favor IL-6 inhibitors or JAK inhibitors. There's some evidence that will support that. And the only change in that is that there's a little star that says when you're using JAK inhibitors, you should think about the risk factors that I've already mentioned. Then we move on to number 10, and there's been a very small change here, and this is because we now have more ways of blocking interleukin-6. So there are some slight changes to the discussions around that in terms of changing from one class to another, and the fact that you now may be able to change within the IL-6 inhibition class. Okay, and then finally tapering. And when I was first thinking about this, I mean, often we're interested clinically in being able to taper, particularly biological therapies, and there's lots of experience of doing this around the world. But in relation to safety, you do start to think about the relative benefits. So, you know, there were justifications for tapering around saving money. Perhaps that's less compelling now that biosimilar therapies are not as expensive. There's the instinctive that less therapy might reduce adverse events, but if TNF inhibitors in oral surveillance are relatively protecting people from certain events, then perhaps we should have a little bit of a careful think about tapering as well. So what's changed in this? Well, there were 2 recommendations about this before. There is a slight contrast here with the FDA, with the ACR's approach. And in the ACR setting, it would be to think about tapering away biological therapies second to tapering away CSD-MARDs on the basis that people get to biologics by already having failed CSD-MARDs. I think there's some logic in that position. For most people, I think the tapering has tended to be around biological therapies. And the other thing I think that's important is that we really want to have tapered steroids before we start tapering the disease-modifying therapies. And that's now enshrined in the 11 and 2 recommendations from the previous recommendations being merged into one over on the right-hand side after glucocorticoids have been stopped. Then thinking about reducing either biological therapies or CSD-MARDs if people are in sustained remission. Okay, so let's just run through in the last couple of minutes. So where this leaves us, you remember I showed you these figures before. So that was from the previous recommendations, the ones that are published. This is now those that were published, and you'll see top right preliminary form. This is in press at the moment, in process, but this is it as far as we know. So clinical diets of rheumatoid. What's changed in the middle, combine with short-term glucocorticoids when you're starting the CSD-MARD, but reduce and stop as rapidly as possible. So it's being more robust around stopping glucocorticoids. And I think, you know, that's to reduce the comorbidities and risks associated with that. Then if we move down, if people are failing the CSD-MARDs and they're in the poor prognostic group, then the wording has changed a bit. So add a biological DMARD. So it's favouring biological DMARDs, and then consider a use of JAK inhibitor therapy only after risk assessment. And we'll come back to what those risks are in just a moment. Nothing else on that slide changing. And then on to phase 3. So if you're failing again, of course, the risk benefit is different here because these are people with very resistant disease and they will often need to be treated. So you may take a greater risk in this particular population. Change the biological DMARD, or the JAK inhibitor on the left-hand side is unchanged. And then just to look about the risk. So at the beginning, I mentioned the fact that this is about, do you divide people up into high-risk groups and low-risk groups and treat them differently? Do you treat tofacitinib as a risk or do you treat all the JAK inhibitors as a risk? Now, if we were going to define the risk factors, here are those that are in the EULAR recommendations. So the following risk factors for cardiovascular events and malignancies must be considered when using a JAK inhibitor. So age, history of smoking, cardiovascular risk factors, and risk factors for malignancy or thromboembolic disease. So calling out the risk patients for us to make that decision. Okay, so that's the summary of what I've been talking about. So as I mentioned, these recommendations are in press, so soon to be published. Corticosteroids have changed a little bit, more of a robust use but stop. Ordering of JAK inhibitors and biologics have changed a bit. It's now favouring biologics and saying you really need to think about the risk factors that I've already outlined in these people. And of course, to update I mentioned the advisory committee, the PRAC committee's view that has been given to the European Medicines Agency as well. For tapering, stop steroids first. And if we're going to taper, I guess think about what other risks may be introduced by tapering, along with some benefits as well. And also, as always, this depends where you work, doesn't it? You know, what's the comorbidity status in your patients? How old are your patients? What are their risks for these diseases? There's some, wonderful data now coming out of some of the studies from Japan, which are whole population studies of looking at the use of particular JAK inhibitors. That's a very different risk population to perhaps the European population I look after in Southampton in the south of the United Kingdom. So it's very context dependent. And that's me finished. So thank you very much.
That's brilliant, Chris. Really nice, actually, to put in the wider context of RA management, bringing in concepts like tapering glucocorticoids. I'm sure there'll be lots to discuss. Please do put in your questions in the Q&A. Please don't hesitate. But we will now move on to the final talk, Professor Dagna, who has the enviable task of being able to guide us in terms of how we put all this information together in terms of clinical applications of the recommendations and the safety data of use of JAK inhibitors. So Lorenzo, over to you. Thank you.
Thank you very much, Maya, for the presentation. It's quite complicated to answer from this question because as the two previous speakers has pointed out, there's a lot of information that is coming out from studies. Many of the data that are generated are a little bit conflicting, or at least apparently not so conclusive. So the clinician, and I think that I'm sharing this opinion with the people that are here speaking at the meeting, because all of them are clinician and taking care of patient, may be a little bit confused. So I will be trying in the next minutes to share with you how probably the idea and the feeling, the general feeling of the clinician towards this class of drugs may have changed according to the events that have been summarized in the previous talk. So those are my disclosures. So we have been, as clinicians working with patients with rheumatoid arthritis, we have the chance of seeing a significant increase of the available molecule. If we go to this timeline, actually, you see that there's been in the last, you perfectly know that in the past 20 years, a huge amount of new drugs have been available for treating rheumatoid arthritis. And so the choice now is is something that is helping the physician to treat the patient. And actually, since we know, and also we kept a greater understanding on the pathophysiology of rheumatoid arthritis, we know that a significant number of cytokines and cell types are involved actually in the pathogenesis of the disease. And considering that the, let's say, more recent strategy for interfering with disease activity in rheumatoid arthritis almost pointed, if we use BDMARDs, on targeting one single substances, one single cytokine of inflammation, or in other cases, such as for rituximab or abatacept, we aim at treating one single cell type or one single cell type interaction. When a new category of drugs, such as JAK inhibitors, came to our availability, the general feeling was that with one drug, we can strongly interfere with different pathways that may be associated with disease activity. So that particular class of drug was deemed to be interesting because it could be able to contrast somehow with the pleiotropic effects of inflammation that is seen in rheumatoid arthritis and not interfere with just one single process. And so actually, this is a kind of draft that I'll be sharing with you. This is that is plotting over time the attitude of a physician toward a new drug. So we know that there's this new class of drug available in the market. And then what it came out were the registration study, and those are a kind of summary of the registration studies for all the 4 JAK inhibitors now available in the market for treating rheumatoid arthritis. And the result of the registration studies were very nice, both in terms of monotherapy, both in terms of combination therapy with DMARDs, in patients that failed TNF inhibitors, in patients that were not responsive in some cases to methotrexate. And also the long-term studies were extremely reassuring. And if we see also what the regulatory agency did with the drug for rheumatoid arthritis, 4 drugs were approved for rheumatoid arthritis. There's a standby for filgotinib in the US, as you know, but actually, and baricitinib, for example, it took a lot of more time to be licensed. Tofacitinib took a lot of more time to be licensed in the EU as compared to the US. But eventually, if we look at this timeline of approved indication for JAK inhibitor in rheumatic diseases, we see that those drugs prove to be effective in many conditions, not only RA, but also other conditions depending on the single molecule. So what it came out, let's say, as if we think of the general feeling of the physician, is that actually this drug could be extremely effective. And if we go back to the 2016 EULAR recommendation, I won't be going through that since Dr. Edwards perfectly discussed that just a couple of minutes ago. But as you remember, in phase 2, so when you fail conventional synthetic DMARD, actually it was proposed in patients that have unfavorable risk factor to add either or BDMARD or a JAK inhibitor. So quite quickly, those drugs came into clinical practice. It was somehow said that current practice would be to use a biological DMARD in those guidelines, and it was also precise that safety and efficacy was not known when we think of cycling this drug after a primary biological DMARD or targeted synthetic DMARD. So the use of a second targeted synthetic BDMARD was not clear in terms of efficacy and safety after a failure of the targeted synthetic DMARD. But then actually, those guidelines put the physician in the condition to prescribe early targeted synthetic BDMARD with no specific limitation. And even the following update, and again, this was discussed again a couple of minutes ago, so we're going quickly on that. They just added a kind of clarification. They deleted the fact that current practice would have been BDMARDs as a first choice. But it was introduced for the first time that we should be considered potential contraindication, and probably at that time the more important and more significant contraindication were the data on thromboembolism to be considered. So at that time specifically, the attitude of the general attitude of the physician toward this class of drugs were increasing up, and as quite often happens after a drug is marketed, the general feeling was that this drug, this category, is perfectly fantastic. And so what actually was I would say that could be sharing with me the attitude and the use in clinical practice of JAK inhibitors. They were broadly used in all the conditions in which they were marketed for, namely after conventional synthetic DMARD failure, after biological failure, and even after targeted synthetic DMARD failure, cycling different drugs. As it was pointed out by the guidelines also, there was clearly a significant interest in monotherapy when the patient, for a number of reasons, could not take a conventional synthetic DMARDs as a baseline drug. And there were maybe some specific subjects of population. For example, imagine even that there's not much literature about that. I think about patients that have extraarticular manifestations such as lung involvement. There were some data suggesting that the usage of targeted synthetic DMARD may be an option, better option than other drugs that are out there. So there was a huge enthusiasm toward this class. Clearly, there was a significant attention in patients, specifically those that had a history of venous thromboembolism. And of course, there were different attitudes in different hospitals in different parts of Europe, depending on the general attitude of the prescribing physician. There were many of them that were early adopters, so started very early prescribing JAK inhibitors to many patients. Others, they preferred to wait a little bit and stick to other drugs. That also was a reason. For example, in Italy, you may know that we have different health systems in each region, and some region actually force clinicians to pick up some specific drug, namely TNF, before using targeted synthetic DMARD, and also other countries in Europe did the same. So there was a kind of, let's say, not unique attitude, depending also on some local restriction and regulation, but there was a great enthusiasm, I would say. Then it came out the oral surveillance study. I won't go in details on that because again it has been quite well discussed in the talk by Dr. Strangfeld, but also in some remarks made by Dr. Edwards. And as you perfectly know, there were actually some specific consideration connected to the study that pointed out the fact that there was a numeric increase in patients that had received tofacitinib with regards to TNFs in terms of cardiovascular mortality and in terms to malignancies. There were some actually consideration about that were pointed out. I just pick up some of them. For example, some problems with the fact that the study started with 10 mg twice a day in the US, and then it was reduced back to 5 mg because of there were problems emerging in the patient treated with 10 mg twice a day. The signal about malignancy was somehow different in different subpopulations of the world, for example, North America versus the rest of the world. And for example, there was an increased risk of lung cancer and lymphoma in JAK inhibitors versus an increased risk of melanoma in TNF. So it was not so generalizable. And there were a different signal about thromboembolism. And the most important thing is that those data conflict with the accumulating real-world evidence suggesting a more safe profile of JAK inhibitors. Indeed, I pick up again the study that has been already discussed, that was the STAR Array study. And as it was discussed before, the STAR Array study is based on the identified data from an insurance company in the US. And actually, they constructed a real-world evidence cohort that were routine care patients, but also they matched those patients in the second cohort with the criteria, inclusion and exclusion criteria that were used for oral surveillance to calibrate results against the finding. And as you can see here, and has been already discussed, there were no significant differences between TNF inhibitors and tofacitinib in terms of safety. This is cardiovascular outcome when we analyze the data from the STAR Array study and those cohorts. As Dr. Edwards pointed out perfectly, there may be biases in selecting patients because probably it may be possible that in real world we do not select patients that may have some specific cardiovascular risk factor. But again, the second cohort will be somehow, let's say, reducing or diluting a little bit this point because actually it was matched for this specific population. And also many of these patients were put on JAK inhibitors early before we haven't even have the notice of the increased risk of cardiovascular problems in patients treated with JAK inhibitors. The other point that probably a clinician that is working with this drug is facing, and at least it creates some kind of doubts, is that we perfectly know that although those molecules are in the same class, those molecules have a different affinity and activity over the different JAK inhibitors. The JAKs, and so we perfectly know, for example, that some of them are more effective on JAK1, some of them may have the same activity on JAK1, 2, and 3. I personally I'm not that sure that this activity is clearly an indication of a major power or a major or safety or whatever, but the point is that clearly those molecules have different activity. They are able to neutralize cytokines, reciprocal cytokines at a different level, so they behave as probably a different drug. And again, most of the data that we have been generalizing on the study and the select on the oral surveillance study and the other studies are generated by a limited number of JAK inhibitors. And so the clinician said, okay, I've been told that those molecules are different, have different pharmacokinetic and pharmacodynamic activity. Why we should be generalized from one single drug to the entire population of drug? Clearly, we should be acting probably on the side of prudence. And so this is the reason for which we do that. But there's something, let's say, from the intellectual point of view that is there that is putting out some problems in the discussion. And indeed, as you perfectly know, there came out this decision by the FDA and the EMA to actually, the EMA first acted just against tofacitinib and put no specific limitation on the other drugs, and said that patients more than 65-year-old, people having a history of smoking, and those with risk factor for cardiovascular disease or malignancies, we should be using tofacitinib only if no suitable alternative exists. Whereas if FDA pronounced saying that all the drugs should be used just when you have an not adequate response or intolerance to one or more TNF. And also that we should analyze the specific risk factor for the patient, and in order to be sure that this is the right class to be chosen for the patient. We perfectly know also that EMA started the review just Janus kinase inhibitors, and the PROC came to the conclusion that Dr. Edwards shared with us a couple of minutes ago. And clearly enough, that would be something relevant for the future when the decision will be actually adopted, if it will be adopted in the same formulation by the CHMP and the European Commission. But clearly, there's another information, and also that will be the subject of the next webinar. And as also Dr. Edwards pointed out, there has been a change in the recommendation made by the EULAR. I just stick to the number 8, which is the relevant to this discussion. So we should be adding a BDMARD when the treatment target is not achieved with the first conventional synthetic DMARD strategy, and poor prognosis factor are present. And so JAK inhibitors should be considered, but pertinent risk factors should be taken in account. And those risk factors are cardiovascular event and malignancy, so specifically age for risk factor for cardiovascular events and malignancy, and specifically is age over 65, history of current past smoking, other cardiovascular risk factor, other risk factor for malignancy, risk factor for thromboembolic events. This is extremely precise. This is a recommendation for a scientific society. I'm a little bit afraid as a clinician if this same recommendation will be endorsed by a regulatory agency, because actually what we define as a cardiovascular risk factor, rheumatoid arthritis is a cardiovascular risk factor. A risk factor for malignancy, we should be exploring in depth the potential, even not known risk factor for malignancy. A familiarity for malignancy is a risk factor. So it's something that probably the regulatory should be pointing out better in order to provide us with nice help to treat our patient at our best. The point is that after this data, it came to us the phrase that probably has been attributed to Hippocrates, which is primum, definitely Hippocrates said it in Greek, but in Latin is primum non nocere, which is first do not harm the patient. So actually, the attitude probably is changing a little bit and is moving to the fact that this is a kind of extremization of the point, but you will risk that you take the drug that you said that is fantastic, that was wonderful, that was treating all the patient, to something that may be dangerous to the patient, as those data seem to suggest. And so probably after those information came to the public, there has been a change in clinical practice for using DMARDs, for using targeted synthetical DMARDs. And actually, probably the general opinion and what is seen also is that clearly there was a reduction of the use as a first line after conventional synthetic DMARD has failed. Physicians start prescribing maybe a little bit more when you fail a BDMARD or one or more BDMARD, and consider clearly in this reduction, one of the drivers that could be there is that since there are several data suggesting a very good efficacy of targeted synthetic DMARD when monotherapy is required, the need for monotherapy could be a driver to, let's say, go a little bit early in the prescription timeline. And again, surely the physician, the clinician now take in a significant account all the risk factors that have been listed before choosing the treatment for one patient of theirs. What is actually a point that somehow emerged also in the previous discussion is that we should be taking clear in our mind when we decide which drug we use, is that there are several data suggesting that, for example, if we treat two targets, so if you obtain the target to our patient, the cumulative incidence of cardiovascular event is lower than if we don't treat the patient in a good way. So if a patient is kept on a moderate disease activity because actually we do not want to use a drug that potentially could be contraindicated in this patient, and we finish the other drug, actually the fact that the patient is not in remission is one of the major drivers for cardiovascular events and also for mortality. As this also was quite known, this graph dates back to 2001, and it showed that there's a significant correlation between the survival probability and the degree of disease activity that is there. So probably what is the right thing, and hopefully in the next years or months or years, as accumulating evidence will be accumulating, suggesting the best strategy to use this drug for is not to consider neither this drug class per se fantastic or bad, but the point is that the physician should be aiming at get all the data from the patient, from the literature, in order to stick for a very, very personalized treatment for the patient. So we should be using this drug for the right patient at the right time, at the right dose, and this thing will be probably the best use of this drug and whatever drug we were thinking of for our patient. And so to go towards, as I said before, this personalized medicine, which is one of the aims that the clinician should point to. And I thank you for your attention.
Thank you, Lorenzo. Lovely end to the three talks that I think, again, raises lots to pick out, actually, and disentangled. We're on to the Q&A session. I know there are a few questions already out there, but please do keep adding. I'll just answer one of the ones very quickly. Chris alluded to this about the EULAR recommendations and when they'll be coming out. Chris, they're in press, so it should be sometime soon. Watch this space, correct? So there's an interesting question on the concept with the PRAC recommendations and the notion of no alternative therapy being available to consider JAK inhibitors in those high-risk groups. So 2 points. I mean, Chris, if I could come to you first, you talked about risk stratifying based on the data Anja showed and you showed in terms of past history of atherosclerotic cardiovascular disease and no past history. How would you implement that, I suppose, in the context of the recommendations and where we talk about no other alternatives and these risk factors? Could you add a bit more of your thoughts?
Yeah, I think that's an excellent question, and it can get very complicated, can't it? So if we think about the most complicated scenario, which we probably want to avoid, we try and absolutely risk profile absolutely every patient in great detail, looking for every single cardiovascular risk factor. And in reality, I think that would be very, very difficult to do. So, I think I would probably end up and doing what I hope is a more pragmatic approach to that. So I think age becomes a very useful cutoff in which most people less than 50 without an obvious cardiovascular risk, it's going to be pretty safe. And as you get older and older, it's going to be less safe. I also would think about just looking at the criteria. You know, if we're sticking to criteria as the evidence showed us, the oral surveillance defied people's cardiovascular risk on certain things. And if you stick to that, that would be true to the spirit of that. I don't know what everybody thinks, but I've certainly had this discussion before. The idea that we will all be doing cardiovascular risk stratification, everybody, perhaps we should, perhaps I should be less lazy and do this to all my patients, but I just think that's going to be difficult. And then the last thing to say is that I think it depends how early you're trying to use it. So in the environment I'm in, where I'm usually starting someone on a biosimilar anti-TNF first, and then if they're failing, I'm moving on to a JAK inhibitor or another therapy. That's a much easier risk-benefit analysis to do in your head, because these are resistant patients who need treatment or who will do badly. Anyway, that's lots of words, but kind of hopefully encompassing some thoughts.
Yeah, it does clarify, because I mean, the person asking legitimately says no other alternative could mean after your third, fourth, fifth really refractory disease. And I think, Chris, from what you're saying, it's not necessarily thinking in those categorical terms and defining numbers of therapies that need to be failed, but seeing the patient in terms of where they are.
Yeah, I think so. But there is a difficulty now, in the sense that if you look at the FDA, it's very easy to follow what they're saying, isn't it? Because if you fail a TNF, it's fine, but think about the risk. Once you have phrases about having used all other alternatives, and some of the medical press is reporting that as saying, I must use every other biological therapy and every other available treatment, including all the CSD-MARDs, and then get to it. So that's left.
And I'm not sure that's necessarily what's meant.
I don't think so, but that's what it says now.
I mean, Lorenzo can bring you in, because you also made the point that links into Chris's last point. This is about balancing risk with other factors that drive cardiovascular disease, malignancy risk, comorbidity. So the importance of getting disease under control, not forgetting the whole treat to target concept. And that becomes very relevant as well when we're trying to determine with our patient the best treatment.
Yeah, exactly. And for example, there are several data that were outside, to add some other consideration, that were outside the topics and the discussion of today, such as the use of corticosteroids. And Dr. Edwards said, for example, clearly now the indication suggested to keep out corticosteroids from the treatment in the US and to be extremely prudent in the EU. But again, if you don't reach good disease control, you don't only have problems generated by the disease control by the failure of the drug that you're using, but in many cases you will be adding some corticosteroid to relieve patients from symptoms. So you add a second risk factor for cardiovascular problem and in general mortality. And we know there are several data accumulating, for example, about JAK inhibitors, that they are being so quick in acting in many patients. You could be at least containing a lot of use of corticosteroids, or in some cases probably not even use them. So again, I feel problematic from a clinical point of view that we could be too strict on defining the single things. I quite appreciate the EULAR effort to say, taking consideration point, we do every day when we prescribe aspirin, and we say, okay, you may have gastric problem, but probably the risk is completely nothing with the benefit I'm giving. So this is something. But when you say you should be doing 1, 2, 3, 4, 5, 6, 7, without even citing the fact that our aim is to control disease activity, that could be problematic.
And I'll just pick up on, because Chris, I think, very nicely highlighted from the recommendations exactly the point about glucocorticoids, the need to taper and stop glucocorticoids. We're often promiscuous with steroids. They continue, even though the recommendations say stop within 6 months, we often don't. So I think that's a really important point. Anja, maybe I can just pick up. Lorenzo talked about how to, in a sense, explain the risks. And I think that's a really important point, particularly when it comes to discussing with our patients when various options may be available. We've been hearing more and more how to translate the kind of data you presented, and we've heard generally in terms of the concept of numbers needed to harm or numbers needed to treat. What's your sense on how we could potentially use because it's very difficult to explain to a patient when we're talking about risk has increased and we give figures from trials. That's very difficult for a patient to conceptualize. When I've spoken to patients, they've often said, but I want to get better now. And if I get better now and my disease is better now, won't that be good for me? And so what's your thought on how we can translate trial data to a form where we can have that conversation with the patient?
Yeah, I mean, that's a real very important point. And I was already thinking when Chris pointed out to the number needed to harm, that is something we can, even we as physicians can work with, because it's sometimes really hard to understand what is coming around all those complex models. So I don't think it's very good translatable to patients, but I think the first step is made if we are both patients and we are aware that there might be something, and we can ask them to monitor themselves, for example, on if we talk about melanoma or non-melanoma skin cancer, to monitor themselves and to go to the dermatologist in time, or now cardiovascular risk or venous thrombotic events that might be occur, that we could just inform them on signs and symptoms without putting them on a thing that they are afraid of this treatment. I remember when we first used TNF inhibitors, we all had to recommend and to advise the patients on the increased malignancy risk and lymphoma risk, and which was later on found out that it was mainly disease activity that was driving it. So I'm a bit reluctant in telling them everything that we find out now.
It's contextualizing, isn't it? I suppose it's contextualizing for the patient. Yeah, no, absolutely. I mean, I'm just mindful of some questions coming up. We could keep discussing on these themes, but I don't want to miss some of the questions that have come up. But Chris, data in terms of individuals who may already be on anticoagulation for venous thromboembolism and how we should be approaching JAK inhibitors. Could I just come to you on that?
Yeah, I think I would still treat those people as being at higher risk. I mean, probably the risk is mitigated by them being anticoagulated, but I don't have information that would allow me to say I know that completely mitigates the risk. And maybe, you know, if there's a slight difference in the pulmonary emboli that occur intrinsically within the lung without DVT, if that's a different pathology, I don't know if warfarin or a DOAC will protect something from that. So I still think I'd include that group. And I think all of those groups, you know, there's the disease activity part of rheumatoid, isn't there, that's driving part of the VTE risk, but all of the normal risk factors pertain as far as I understand. So age and obesity and oral contraceptive use and surgery and, you know, all the things we'd normally, and being on warfarin for clotting means you've clotted or you're at high risk. So they're still a high risk group to me. If that
they are a high risk group, but I think you're right. I mean, there is a lot of, I think in the clinical context, there's sometimes a pragmatic approach that's undertaken. And again, it's all about what options are available, the importance of keeping disease under control, minimizing immobility. And so I think there is sometimes sense that if a patient is already on anticoagulation, that some element of that risk would be mitigated. But I think, as you say, Chris, identifying them as still as a high-risk group is important. I suppose to the person asking the question, it wouldn't necessarily mean that would discount and dismiss use of JAK inhibitor in that context, because some element of risk would be mitigated, but the individual factors need to be taken into account, as you say, Chris.
Also, if I may, we should take in consideration the fact that at least some of the JAK inhibitors have the same metabolism route as oral anticoagulant. And so also, this is clearly not a problem, not an issue when you use an antibody. And so probably also that will be driving and we should be taking in consideration. Although, as I said, I mean, again, if this is probably a prototypical patient that if we go very strict on the indication from the regulatory agency, you should be never be able to get a TTS DMARD, a JAK inhibitor. Although it's possible that at least there is maybe a limited category of those patients will be really benefiting from them, because with other drugs we won't be able to reach the disease control. But again, it's something should be again put in a general consideration, as we have discussed before, individualizing and tailoring the treatment to each patient.
Yeah, and I think it comes to the point you were making in your talk that there may be certain subgroups where JAK inhibitors are more appropriate to be in monotherapy, certain subsets based on comorbidity, etc. So all these should be taken into account. There's an attendee that says, how on earth do you communicate the risks? It's difficult for clinicians, nigh on impossible for patients, but I think contextualizing is a key theme. Chris, there's a question about, again, coming back to the PRAC decision and how this aligns with EULAR 2022. Your thoughts on that? They are broadly, but maybe you can give your thoughts.
Yeah, I think they broadly align, don't they? I mean, lots of this is about words and exactly how you interpret it, but I don't think anyone should get too hung up on slight differences between the wordings. Clearly what both say is that you should take JAK inhibitors as a group. That's clearly the case, and it weights more towards using biologics before using a JAK inhibitor and risk assessing, and both do the same thing, and I think that's okay. They group it, they risk assess, and they hint towards biologics first. So I think they're saying broadly similar things. Same thing. Yeah. Just to make one comment about that, I think it was Martin Lee who made the comment about this is difficult to express risk to patients. I mean, one of the and I was just quickly looking at one of the SPCs for one of the JAK inhibitors. Of course, one of the things that SPCs do is they create that table of adverse events, and they say common, uncommon, very uncommon, and it's 1 in 10, 1 in 100, 1 in 1,000. I think most people can understand that conceptually. And I find that quite a useful way of talking about it. But it does come back to the vital bit of taking the patient and saying, this book has a page on each side of the book. It has risk and it has benefit.
Exactly.
I want to tell you about both. I don't just want to terrify you.
And that's the important thing, isn't it? A single lens approach doesn't work in terms of getting the best management. I mean, the PRAC recommendations are interesting in terms of, and Lorenzo, you alluded to this, in terms of the risk factors that are identified. I mean, Anja, Lorenzo, your thoughts on age is clearly identified, and Anja, you nicely demonstrated how not just for cardiovascular disease, but infection as well, age starts becoming a risk factor. What about the biologically well over 65-year-olds? So again, it's how we implement these kinds of recommendations. Are we saying that these should be hard measures? You can get a comorbid 45-year-old and a biologically very well over 65-year-old, and how would you negotiate that?
Yeah, that's also a good question. I mean, there are so many. We had this sub-analysis with elderly patients above 70, and there were some that were really healthy. They did not have any comorbidity and anything. So I don't know if I would throw them in the same bucket as those patients. I mean, that are above 70 or 65 and have a lot of comorbidities, and but which is the main proportion of those patients?
I mean, we've had a really good question just come up that's triggered, and I've often said the same thing. How about actually, rather than using it later, and I've written here that use it later and later in a refractory group, they're the most comorbid group, they're the ones at highest risk of malignancy cardiovascular. This question is saying, should we not be turning it around? Use it in the younger patients, as Chris was saying, where there would be less concern, those with no past history, before they get to the older age group and have had time to acquire all these risk factors. It's a very relevant point.
Yes, I think so too. and we know that with every treatment failure, it is the risk for another treatment failure is increased. So a lot of patients that are treated with JAK inhibitors in the registers, in the claims data, had much more treatment failures than their comparators in the TNF treated groups. So
Maya, can I just looking at that last question that you were mentioning that popped up, it also shows one of the potential crazinesses of us overreading and data, doesn't it? So some of the discussions around this are sometimes around, if you say 65, you've started someone at 64, what do you do on their birthday? Now that's clearly the question people ask, but pragmatically, that would be ridiculous.
It is not, no.
So we must just be flexible with all of these things. We mustn't be tied up in knots by the exact words.
And I think that's the crucial message, really, isn't it, in terms of recommendations and how to use. Just a very quick last question, and I know we're sort of running out of time, but when can we expect data on non-tofacitinib JAK inhibitors? I'd argue as well, I think what oral surveillance has shown is the importance and the value of trials that are looking at specific safety signals across targeted therapies, not just other JAK inhibitors. Anyone like to volunteer thoughts on that? Not necessarily on when we can expect, and we are going to see some data with baricitinib, I think, and whether we're going to get similar data to oral surveillance is another matter. It's a big undertaking. But thoughts on, should we be undertaking these kinds of studies to get a better handle on specific safety signals of concern?
Maya, I think naturally we will see more and more data on the baricitinib treated patients and as well on filgotinib and upadacitinib treated patients in real world, because they were approved later on, and like the Swedish data and the claims data that are presented from France, they already have a very high proportion, a higher proportion of baricitinib treated patients than of tofacitinib treated patients. So I think this is a US, American and European difference.
Yeah, absolutely, yes. Sorry, Lorenzo, did you wish to come in? No.
No, okay.
And maybe just, there's a final technical question I've missed. I'm not sure if I've answered it correctly. Why was it decided to apply the same methodology to assess cardiovascular risk as used for oral anti-diabetics? I think that's speaking to stratifying into past history of cardiovascular disease, none, and then within that risk categories. If I've understood that correctly, it's because in type 2 diabetes particularly, they've shown that there's different, within trials of interventions, that there are different outcomes for cardiovascular events based on risk stratification on past history, presence of past history or not. I'm not sure if that answers the question or that was what the question was, but I think that's what you're trying to say. I don't know if there are any final thoughts. We could actually, there's so much that can be discussed. I thought, Chris, your point about tapering was so valid as well. Reconsidering, many have often said, authors have often said, we talked about treat to target for 20 years and we don't want to risk subverting and jeopardizing disease control with tapering when it's mainly in a blind fashion. And I think your point about now cardiovascular comorbidity, etc., I think that was a really important point as well. I don't know if there are any final points anyone wishes to add before we move on. No. Okay, so we're just on right time. If we could just summarize and close. So essentially would like to thank our speakers for, I think, 3 brilliant talks that really captured the clinical conundrum in a sense that we face and how to interpret these data, both from trials and real world evidence. I'd like to thank you all the attendees for listening and for participating. It's what makes it enjoyable for us and always a learning experience for all of us. We do all hope you've enjoyed the webinar. Please do fill the evaluation form. It's really important. It just helps us improve these webinars and initiatives going forwards. The live stream version, it's now available, so it can be viewed on YouTube on the Cytokine Signal Forum channel. So please do have another look if needed, just to recapitulate and capture some of the discussion points. And this is just to advertise the next webinar. It will be in early 2023. Can't believe it's already the end of the year, but early 2023, where we'll pick up on some of the points already raised about the regulatory updates. So this is the next webinar on clinical management of JAK inhibitors in inflammatory arthritis, implementing the regulatory updates. It will really build on discussion today, so please do look out for that. With that, I'll wish you a good Friday and a good weekend, and hope to see you soon. Bye.